Thank you, Senia. Good afternoon to all. As Senia mentioned, this is our last session. Today we are going to learn about end of life care and medical ethics. This session will be taken by Dr. Sreedevi Warrier, who is a palliative care physician having more than 10 years of experience in palliative care. She did her fellowship in palliative care from Institute of Palliative Medicine, and also she did her MSc palliative care, MSc palliative care from Cardiff University, UK. Now she is heading the academic division of Pallium India. Madam, welcome and over to you.
Thank you so much. Am I audible? Because
Yes,
I
yes.
have some problem with the microphone. Is it clear?
Yes, yes, ma'am.
Okay.
Yeah.
Just give me 1 minute to two presentations. I'll start with the medical ethics. I'll start with the basic principles of medical ethics. Then we'll have discussion based on that. And then we'll move on to the end of life care part of it, which will be a continuation to medical ethics, but I am just giving two separate presentations on for both. So have you heard the word morality and ethics? Some you might have heard people telling, oh, it's against my moral principles, or it's against my morality, or sometimes we use the word it's against the ethics. So what is the basic difference between the morality and the ethics? Anyone would like to just tell me? And there is no right or wrong answer. Even it's very difficult for me also to explain the difference between morality and ethics. You can either type. We always use, it's not moral, it's against my moral values. Sometimes we say it's unethical or it's against the ethics principles. So what is the difference between morality and ethics? Anyone? I can't see the chat, so if there is any, yeah, I can see the chat, no problem. Yeah, yes, Mr. Jaya Sharma. Ethics are a set of standards. It can be from the institute, or as you mentioned, or it can be set by the society. Ethically, that is wrong. So there is, suppose there is a traffic signal, which is showing red light, and it's early in the morning. There is no vehicle around. Some people can cross the traffic light, right? Because there is no vehicle anyway. There is no camera set there. You can still cross the traffic light because it's so early. No other vehicle. You are not going to do any harm. But some people say, no, it's not. It's against my moral principle. When there is a traffic light, irrespective of whether I'm going to hit or not, I'm not going to cross the road. So that's a very simple difference between morality and ethics. Or even the medical termination of pregnancy. Some people, it's morally, we can't do the termination of pregnancy, maybe due to some religious reasons. But technically, in an institute, if the institute is not against the medical termination of pregnancy, you can do it. So there's a slight difference between morality and ethics. These are definitions. You don't need to read the definition. But morality or moral is basically principles of right and wrong behavior. You are not supposed to talk like this to your parents. And ethics, as Sister Jia was mentioning, it is connected with beliefs and principles about what is right and wrong, and generally it is set by the society or by an institution. And medical ethics, definitely for people to practice, there are governing decisions in the medical practice. So there is a slight difference. Morality is more like an individual based. My morality will be different from this Sister Shiba's, although we work in the same institution. But the ethics principle should be the same because the institution has an ethics. So we have to follow the basic ethics principle in the institution. As I said, MTP, medical termination of pregnancy, is not morally acceptable for many people. But again, if you look at the legal perspective, it is legal, so it is ethical. It's nothing to do against the ethics. It's all the moral principle that will tend people not to do MTP. I just want to bring out the difference, because when you come across the ethical dilemmas, sometimes a moral value sometimes make us confused whether we should do or not. Suppose a patient is coming, which you morally don't agree, but ethically you can do it, or legally you can do it. So these are the things which will keep playing in your mind when we come across the ethical dilemmas. And there is no clear-cut right or wrong answer when it comes to ethical dilemmas. It is always our ability to understand the difference between what is good from what is bad. Not for us, but for the patients or the families that we care for. And what is appropriate. Sometimes which is good, a few practice which we feel it is good. Feeding when someone is dying, we feel that it is good. Or not feeding, which is good. We know that feeding is going to harm the patient, but it may be culturally inappropriate. Sometimes some religions want to feed. In our homes, we want to feed the person when someone is dying. We want to give Gangajal. We know that we cannot feed, patients can aspirate. But saying that you cannot give that becomes culturally inappropriate. So we should be able to understand or distinguish what is appropriate and what is inappropriate. And we have to have that commitment to understand for the patient what is appropriate in a particular context. So someone not dying, giving a glass of water is okay. Someone who dies, who is dying, who has a possibility of aspiration or having end up in a lot of mess, that's different. So we have to understand, we have to put in an effort to understand whether it is appropriate for that individual in that particular context. So what is a dilemma? It is a conflict of moral principles when certain situations, especially in palliative care, as you have seen in communication, where the patient's families do not want to tell the patient about the illness, right? So there are certain situations where we feel, should we tell or it's better not to tell? So these are guided by our moral principles. So I was a person who always wanted to tell the patient or convince the family, please tell the truth to the patient. But it occurred to me that one very elderly person in my close family circle, when he was diagnosed with an end-stage cancer, he had only 5 days to live. I was totally confused. What is the point in telling? He just have a few days to live. He's already having a terminal cancer. So we face all these dilemmas every single day. I know that it is ethically right to tell the person, but morally, sometimes I feel that I'm obliged not to tell. Or as a close family member, maybe I am obliged to not to tell the diagnosis. So these are one example. There are so many examples. Some people may ask you, can I, doctor told me to do the palliative chemotherapy. Shall I go for it? Should we stop it? Should I stop the diabetic medications when someone is very sick, when someone is not eating, drinking, going to die? So there are a lot of conflict of moral principles when we face certain situations, and it is more and more in palliative care because we respect patients or individuals' wishes. We want the best for them, right? So we'll face more and more dilemmas there. So this is one scenario that I would like you to think. This is a 55-year-old man who developed dysphagia. Dysphagia is difficulty in swallowing due to an incurable advanced carcinoma of oropharynx. So this is a person, 55-year-old man, who is unable to swallow because of a cancer in the oropharynx. Very advanced. Otherwise, he is very healthy. He is okay. He's trying to talk. He's unable to talk because the voice is a problem because of the lesion. But he's otherwise so healthy. He goes to the toilet, everything on his own. He takes care of ADLs on his own. Pain is well controlled. He's otherwise quite healthy. And we feel that you need to put in a nasogastric tube so that you can feed. So nasogastric tube in India, it is for feeding. In other countries, it may be for venting. So we put NG tube for feeding. So we feel that, okay, anyway, this person is very healthy, walking around without much problem. Why don't we put in a nasogastric tube so that he will not be hungry? He can live longer, right? Otherwise, except in the oropharynx, he doesn't have any problem. He's fine. But he tells very clearly, I do not want an NG tube. What will you do? I'm waiting for some responses. You can type or you can tell. How should I go about it? I'm sure as a palliative care nurse, if you start working or if you're already working, These are the kind of situations that you come across almost every day. And your colleague nurse will tell, oh, sister, I think that he should get a tube. Or your doctor will tell, no, no, tube is going to harm the patient. A lot of discussion happens within the team. Even in the MD multidisciplinary team, people will keep arguing, no NG tube, yes NG tube. And the family will tell, please put the NG tubes. Yes, as far as possible, we depend on the liquid diet, small feeds. But we feel that NG tube can actually benefit. We can use either TPN or IV. He told, no, I do not want. I need to eat. If I am eating, I need to eat through my mouth. I don't need anything artificially. I can't stay in hospital. This is a real scenario. This is what he told. I don't want to stay in a hospital. I want to go home. If I am eating, I want to eat through the mouth. But he is otherwise healthy. Anyone else? I heard from Saraswati and Kalevani. Anyone else? Yes. Explain the importance for NG tube. If not, then dietitian referral for shifting the patient to soft diet and liquids. Yes, one option. And give only oral small feeds. Sorry, advantage of NG tube you will explain. Then also he is not, leave it to him. Encourage the patient to take small amount of liquid bland diet. Thank you so much for the responses. Yes. So I asked him first question, why he is telling no to NG tube. What is the reason? He might have seen, if you see in an oncology ward how people put in Ryle's tube, I would not want it at any point of my life. I've seen a few. There will be so many people, like especially when you have a lesion, like it's quite a struggle, right? They'll be scared. And putting in something to the nose is something which people are very scared of. So first thing to ask, where you start, ask why he doesn't want a Ryle's tube. So this patient told me, I don't want Ryle's tube. I have seen a guy walking around with Ryle's tube near my house and he died. He died after some time. I told, no, NG tube. So he thought initially that putting in NG tube is for people who are dying. So I sat with him and I told, that might be a misunderstanding. It is for feeding. So I explained everything. Then he told, if I'm going to die, I want to die like this. I don't want people to see me with a tube in my nose. I want to walk out. I want to walk outside my house. I don't want to put anything which is visible and telling others that I am a patient. So here comes the principle of autonomy. In Greek word, we know that we all learn all these words in the medical or nursing education is all either Greek or Latin. So in Greek, it means self-rule. I rule myself. So principles of autonomy says that understand what does the patient want. And it is about letting them taking their own decisions. If I am a patient, I would definitely want my doctor to tell me what is happening to my body. I want to understand what is the side effect. Okay, doctor, you are putting in an NG tube. What are you going to achieve? I want to know that. I want to know whether it is painful. If I don't want to do any procedure, my doctor should be able to accept it. They cannot force me to do a treatment. So respect for autonomy requires the doctor to give full information. So I can't say, can I put a Ryle's tube? Then the patient says, no. That's not possible. I have to tell why I am putting a Ryle's tube. Because your activities of daily living is so good. You look healthy. You might be able to live longer. You will not be hungry. If I don't put the Ryle's tube, you can take only small, frequent liquid meals, which can make you tired, which can make you hungry. Your lifespan might reduce. So I have to explain or give full information in the language that they will understand. Can I use the word NG tube, Ryle's tube and all to the patient? No, they don't understand. So I have to tell that is a tube that is put to your nose, which will reach your tummy. So when you feed, it won't be painful. I can make it as painless as possible by giving you my anesthetics, local anesthetics. So I can, this is what the tube is for. So I cannot use the words which they don't understand. They get scared. And I have to give all possible information about the procedure. What is the advantage? What is the disadvantage? I don't know whether you will you remember Dr. Biju said, it is not like giving a menu in a hotel. Whether you want noodles, fried rice, no. You have to tell what is why the procedure is being done. Give them time. He will say no today. Next day morning, he will come and say, okay, let's do it. That's fine. Just give him the time to understand. And the patient should be able to make decision. It is not when he is disoriented. He should have the capacity to make decisions when you ask this. This very rarely happens in an Indian scenario. What happens then? All the relatives will come and take the decision. In India, the son, the daughter, the wife, or the husband will tell you, no, 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 put in the rice tube. Don't ask the patient. Why do you want to ask the patient? He doesn't know anything. He's illiterate. My father doesn't know anything. Just put in the rice tube. We want to feed him. We can't see him dying in hunger. So then it is important for you to sit down with the patient's family, make them understand the pros and cons, make them understand what does the patient want. He has an advanced cancer. Just think about him. Why you are doing this? For the patient. And this is not what the patient wants. So it's important for you to sit with the patient and to sit with the family and to make them understand what the patient wants. And it is something inclusive. That is, you ask the patient what they want. We are including the patient in the decision making, and we respect the patient's right to make decisions. And you have to acknowledge, as this patient told, I don't want to be seen. I don't want my friends and my family to see me with a tube. So I had an aunt who was undergoing dialysis for renal failure. So all her lines were blocked, and then they had to put in a central line when she was becoming sick. The moment the line IJ, they had to put a line in the IJV. So when this was put, there was a cannula there, and she stopped seeing people. She told, I don't want to see people with the cannula here. Fine, acknowledge the feeling, acknowledge the beliefs above rationality. You can't say, oh, what is there in cannula? It is very important. It is okay, let the others see. No, acknowledge the feeling. I don't want to be seen with a cannula. That is fine. It is exactly opposite to paternalism, where you tell the patient what is good for them. So the same person, the 55-year-old man with a carcinoma oropharynx, he underwent a few cycles of chemotherapy. Okay, then he was brought to casualty. He was very drowsy. His pulse was feeble. BP was very, very low with altered breathing pattern. And very typically what the family will tell, please do everything possible for the patient. Please do everything possible. Just don't let him die. So what should we do in such situation? The person is very weak. The pulse is very feeble. Systolic BP is 60. Breathing pattern is altered. What should we do? Should we resuscitate and shift him to ICU? Should we investigate? Should we give a ventilatory support? Should we give nutrition and hydration? How should we go about it? I'll just look for the chats. There is no right or wrong answer. My right will be wrong for you. Your right will be wrong for me. So there is, it's just for discussion. So it is okay to give in your opinions. Investigate. Yeah, definitely. I'll want to see whether there is something correctable. What if he has some sepsis which can be correctable and he lives for some more days? Definitely, yes. I will just do routine investigation just to see whether why he's having all these symptoms, right? And Anything about hydration and nutrition? Yes, very good answer, Saraswati. Ensure all the correctable courses. Do the basic investigations to understand whether there is something which is correctable, which is minor corrections possible. Oxygen support, we'll come to that later. Yes. Management, yes. Is he dying? Is this patient dying? Yes, Sister Sharina, we'll do everything indicated, but the indication matters, right? If you take him to an emergency medicine physician, the indications are different. But what is indicated? Is it to preserve or prolong the life is what is indicated, or making comfortable is indicated? So that word indicated is a little tricky. So anyone who thinks that the patient is dying, you can raise your hand in the reactions. I cannot see everyone together. So if someone is raising hand, yes. Jaya Sharma, yes, raised her hand. Anyone else thinks that this patient might be dying?
If the ma'am, good afternoon.
Yes, yes, please.
If patient is not in a condition to be revived, then one of the main responsibility of the profession, of our profession, is to give him peaceful death also. So by the time counseling can be given to the family members and whatever possible, but not very intense, not very active management is required. And we can manage with the basic things. What I feel. Thank you, ma'am.
Thank you for sharing. And I can see two more hands. And in the chat, Jamelia tells that yes, he might be dying. Yes. So recognizing dying is very, very important. We should be able to understand whether the patient is dying or he has an advanced illness which has progressed, and he has underwent chemotherapy, so his immune status might be very, very bad, and the feeble pulse and the low BP and the altered breathing pattern indicates more. It's more likely that he's towards the dying phase. So here we have to think the beneficence to do good. The next principle of ethics. The goal of medical care, as you mentioned, it is about it. What does he want to achieve? Setting the goal is very, very important. So goal setting for the family in this case was keeping him alive, no matter what. But we have to make sure that how much ever he is going to live, keep him alive with dignity and with comfort. Even if it is 1 day, 10 days, 10 years, no matter what, we need to keep him comfortable. Setting that goal is very, very important. Once you set the goal, then you will be able to do good. So here, if I put in a ventilator or if I go for an aggressive management, that is going to be a futile care. Futile care means care that fails to achieve the benefit. What am I going to achieve? So I have a goal. My goal is to keep the patient comfortable with the family at his home. He already told me, right? I don't want rice tube. I want to be at home. So keeping him comfortable in the place where he wants is my goal. But the relatives are telling me, keep him alive. Don't let him die. So I have to sit down and come to a common goal of medical care. And then I need to work towards achieving that. So what is the difference between how can we tell futile care and benefit? How will you understand? Benefit is subjective, right? For the son, the father living for one more day is benefit. For the patient, living for 1 hour without pain, without breathlessness, without losing the dignity is the benefit. So benefit is very, very subjective. So this is where your morality and ethics should come into play. My definition of benefit may be very, very different from the patient's, right? I feel keeping the patient alive even after giving chemotherapy is my definition of benefit. I am benefiting the patient by keeping him alive for a long period of time. But I have to go by the patient's definition of benefit. What does the patient think? So here comes the role of advanced care planning. It is not when someone is dying, I can't go and ask this patient, what is the benefit that you're looking for? Right? I can't ask him, do you want hydration? Do you want to be in the ICU or do you want to be at home? This is not the time to ask that. He's already weak, he's already dying. So it is very important to have a discussion on advanced care planning well before. So the time when he was diagnosed with an advanced cancer, I have to start the conversation about the cancer, how it is progressing, what is the kind of treatment that you would like to get in future if things progress. There might be. So he told, I don't want rice tube. So what I told him is that you have a tumor or growth in your throat. The growth is growing. So it becomes to a state where you won't be able to swallow even a sip of water. It comes to a point where you won't be able to talk. You won't be able to take even a drop of water, or you won't be able to breathe. If that situation comes, what would you like to get? Would you like to be in hospital? Would you like to be at your home? What would you like to have? So that made things easier. The patient told, I don't want to be in a hospital. Just take care of me. Don't put in a tube. It's easier for me. I can tell the family, we already had the conversation. I have documented it. This is what the patient wants. Don't you think you have to respect your father's wishes? So advanced care planning is very, very important. And the third principle of medical ethics is do no harm, non-maleficence. I have to think whether my treatment have any physical side effects. Whether putting in a central line or an IJV is going to give more infection, more immobility. The patient is not going to get out because he has a I don't want to see the people with this. So, or I want to see a chest X-ray. And the patient has to be transported from here to another department. So am I doing good or am I doing harm? So I have to think whether my treatment have any physical side effects. And it is not just the physical harm, but about an emotional harm. Financial harm. Am I going to burden them financially? Am I going to do a social harm? So it is not just the physical harm, but also the emotional, financial, and the social harm. The last principle, that is justice. So I have to have a balance between the needs of the individual with that of the society. So I'll tell you an example. Suppose this patient wants all possible treatment. I want ventilator, I want hydration, I want this, I want that, I want to go to that big private hospital there, and I want to live in the ventilator, no matter what. So I have to think whether I am doing a fair distribution of resources. A typical example would be, suppose one patient is coming and telling you, doctor told me there is a surgery to my throat. So this patient, maybe the 55-year-old man coming and telling the surgeon told me, you can do a surgery in the throat, you can remove the lesion, then you can live longer. But the surgery cost about 2 to 3 lakhs. It's a very advanced surgery. And he's asking you, can you please help me? I want to live. Can you please help me? And you have 2 lakhs in your hands. You got some money from a funder, you have 2 lakhs in your hand, and this patient is coming and asking you, madam, I need 2.5 lakhs to do the surgery. They told, I can remove the tumor. I can live for longer. I can swallow also. Can we give the money to this patient? How many of you would want to give the money to the patient? Anyone wants to give the money to this patient? I'm looking for the chats. You have money, you have 2 lakhs. The patient wants some money so that he can get an operation done. He's financially very, very poor. So we had instances like where there was a 25-year-old who met with an accident, who had injury at the cervical vertebra, completely paralyzed. He's conscious. He's just 25, recently married, totally on ventilator support, completely on ventilator support, but wants to get a home ventilator, which was very, very expensive, so that he can be shifted, and he wants us to give the money. Yes, we can give, since he has a good chances that he'll come out. That is, Sister Saraswati says that. Anyone else? Yes, Sister Jaya, we can advise them about Ayush scheme, but you have money in your hand. What will you do with that money? You have 2 lakhs with you. He needs 2 lakhs. So what about if I give the 2 lakhs? What about 100 patients that I'm taking care of? I need to give pain medications to 100 patients. With this 2 lakhs, I can easily give pain medication for another few months, not just to one, but for 100 patients. So I have to have a fair distribution of resources. So I will not, right? I have 2 lakhs rupees. I have 100 patients under me. I can just give a lot of pain medications for these patients, or I can help just one patient to undergo surgery, which may or may not succeed. So I have to have a balance between how to use my available resources. So I might tell this patient, okay, let's explore a few NGOs. Let's explore a few funders specifically for you. Whatever money I have, I need to take care of every patient, right? It's not just one patient. So it's all about fair allocation of resources. You might have seen this in COVID times, right? We had to use our expertise for patients who are most likely to survive. You are using your time for people who can be resuscitated, not for someone who is dying due to COVID. Like, how many of you have seen that? That is fair allocation of your time. That's something called triaging. We know that you have to take care of these patients who is more likely to survive. So justice is something which I need to be careful of when I distribute my resources in terms of time, money, or anything. And there is a high chance of conflict within the team, because team feels that this person can survive. We have money. Why can't we just give the money to this person? So these are the dilemmas that we can come across. So how do we decide for him? So there are 4 things that I need to consider when this 55-year-old man coming to me. First thing is what he wants, not his son or the wife, or what I want. What usually happens, what usually we do, what the doctor wants, not even the nurse, right? Even if you don't want to do any intervention, the doctor decides, not even the patient. So it's very important to understand what he wants, and is it a benefit for the patient, or is it my mental satisfaction that I am unable to prolong life for 2 more weeks? No. Whether it is benefit for the patient. Am I doing some harm for the patient? Am I harming the patient by my treatment plan or any of the investigations? And am I using my time or money or any resource fairly? This is called a distributive justice. Am I using my resources fairly to everyone, not just allocating my whole time and energy for one particular patient. And here comes this patient. The same patient is breathless. He's having shortness of breath. He's unable to breathe. And I have given morphine and midazolam in titrated doses. Am I hastening the deaths? Am I killing the patient? I'm giving morphine and midazolam, an opioid and the benzodiazepine together. And the patient is breathless already. Am I killing the patient? Anyone would like to comment? Am I killing this patient by giving morphine? Yeah. No, if it is titrated. Very good answer, Sister Jaya. That's why I specifically mentioned I am giving in a titrated dose. So there I have to weigh the risk versus benefit burden for the intervention. What are the risks? What are the benefits? So if I give midazolam and morphine in titrated doses, the patient can be comfortable. That's the benefit. What is the risk? It can actually cause a little bit of sedation, or it can actually hasten a little bit, like patient can be more drowsy, may not respond. But the patient is going to be comfortable. So I have to weigh between risk and benefit and the burdens associated with the intervention. So as I told in the beginning, ethical dilemmas are called dilemmas because there is no clear-cut answer. I can't tell you, please give this. You are not doing any risk. There are risks involved, but there are benefits involved. I need to think whether I am increasing the risk. So I'll tell you an example. So one patient, this particular patient was very breathless, but he told me that I don't want to be sedated. I want to see everyone and die. Let me get drowsy when I'm drowsy, that's fine, but I don't want to be sedated. So although I know that sedation can make him comfortable, I may not be able to do it. Here comes the autonomy and the benefit. So all the ethical principles can play a lot of role when these kind of things come. It's always recommended to have the team, to have a conversation. It's easier when you converse with the patient beforehand. If you have an advanced care plan, it's much more easier. We know what the patient wants. We know what he wants. It's much more easier. And we have to give focus on the appropriate treatment. We have to understand the aim and benefits of each treatment that I am offering, adverse effects of each treatment. And very importantly, the third point, the need of not to prescribe. We know how to prescribe. We know how to give. Very, very importantly, we have to learn not to give, not to prescribe, not to give an intervention, not to hydrate sometimes, not to go for extensive intervention. So that not prescribe is something that we need to learn. So this is another principle called principle of double effect. It is like a double-edged sword. A sword has two edges, right? Both edges are sharp. To use one edge, you can't cut or stick the sword to one person with one side, right? When you use the sword, both sides are sharp. But it is not just for end-of-life care. What is that principle of double effect? A single act having two possible foreseen effects. One is good and one is harmful. So if you give morphine and midazolam together, there are high chances that patient can become drowsy. He'll be very drowsy. Maybe he might die a little bit earlier. We are not prolonging that there. So, but the patient is becoming comfortable. So my intention when I give these medications is not to kill the patient or not to sedate the patient. My intention is to reduce the breathlessness, reduce the anxiety, keep the patient comfortable. So I am not preventing myself from giving these medications together. So it is a single act having two forces. So if you give an antibiotic injection and the patient dies of anaphylaxis, did you kill the patient? We have given antibiotics so that the patient can get benefit from infection. The patient did not die because we wanted to kill the patient with an antibiotic, right? So the intention to give the medication was different. The intention to give morphine was to reduce breathlessness. The midazolam was to reduce the anxiety. So you have to be aware of the principle of double effect when you, especially in end of life care. So is it euthanasia when I give this morphine and midazolam together? What is euthanasia? Euthanasia is a procedure which someone takes, such as a lethal injection. My intention is to kill the patient. My intention is to kill the patient by giving toxic doses or lethal injection. I'm not giving titrated or the recommended dose. I am giving increased dose or lethal doses so that I can kill the patient. Here what we are doing? We are doing allowing natural deaths. We are withholding or withdrawing a futile treatment. I am not giving ventilator to Mr. H, which is 55-year-old man with advanced cancer, because I know that that is not going to help the patient. The patient doesn't want that treatment. So that is not euthanasia. I'm not killing the patient by not giving treatment. I am withholding a futile treatment. Futile means which is not going to benefit. So this is not euthanasia because we are allowing the nature to take its course. We are not doing anything to kill the patient. We are allowing the nature to take its course and withholding. I know that this is not biologically feasible or it is futile. And I know that giving insulin or giving metformin when someone is dying, not needed. I'm withdrawing it. I'm not doing it. He was on oxygen. I know that this is not going to benefit. I'm withdrawing it. And using morphine and other drugs to relieve pain and breathlessness. These are not euthanasia. And these are the common dilemmas that we see in palliative care. First thing we discussed, patient wants to know, patient doesn't know. The relatives are telling you not to tell. Non-disclosure of diagnosis to the patient is the very, very common dilemma that we come across. In a terminal patient giving a CPR. So I remember when I was working in another institution, when the patient was very sick, advanced cancer, and the patient was dying, and suddenly the postgraduate medical medicine postgraduate students came in and started giving CPR. He broke a lot of ribs there. Patient was dying. Patient was literally dying. He tried to put an IJV, caught into pneumothorax, and then he gave CPR, broken all the ribs, and the patient died. And the patient was a terminal cancer patient. So these are the, and I asked the postgraduate student, what made you give the CPR? I couldn't see him dying, madam. It was a reflex. I couldn't see him dying. I knew that he was a terminal cancer patient, but I couldn't see him dying. So that's a dilemma, right? For him, he tried to save the life. He did something good. For me, and for the patient and for the family, what happened? He had a lot of broken ribs. He had to cry. The patients, it was a general ward. Everyone around him saw the CPR and process. Everyone got scared. The family started crying. The family could not say proper goodbye because the doctor was jumping on the patient for the CPR, right? So for the patient and the family, that was not the right thing to do. They were so upset. But for the doctor, it's a good thing to do. So there is always dilemmas when it comes to palliative care, these kind of decisions. Ventilation in a patient with dyspnea and advanced cancer. In IV fluid, very commonly, the relatives will tell you, please hydrate. He's not drinking, he's not eating. What happens when you overhydrate? I have seen both ends. Where generally see there is no specific evidence, but there are a lot of studies. When you give a lot of fluids during end of life, the patient he'll have more secretions. They struggle a lot when they are dying. So it's Good to maintain the hydration, but not to overhydrate. Oxygen is an intervention. You are not giving oxygen directly from the air, right? You're giving an intervention. And oxygen, you're giving an intervention. So you have to think whether it is going to be futile, it is going to be beneficial or harmful. Whether this oxygen is going to help the patient. If the oxygen is going to help the patient, you will know in the first 10 minutes. The patient has an advanced cancer, right? Advanced cancer here, he's unable to breathe. If you give oxygen, where will the oxygen go through? It's going through the same route, right? And when someone is dying, natural death, suppose a 99, 100-year-old grandmother is dying. If you check the saturation, oxygen saturation has to drop when someone dies. Can someone die in 100% oxygen saturation? It has to come down. It will come down in a natural dying process. There is no point in giving oxygen then. That's a normal process by which the body shuts down. Decreased in urine output, change in breathing pattern, reduced response. All these are part of dying process. And antibiotics at terminal stage. Your immune system is shutting down. You are prone to infection. You'll have more and more infection. You will have sepsis. So antibiotics doesn't have any role when the patient is terminal. That is how generally people die at home. So there is no clear-cut right or wrong answer. It is all about thinking again and again whether you want to look at the patient's autonomy, beneficence, non-maleficence, and justice. So this is not my last slide. I'll go through the end of life care again. I'll take a few minutes on that. It's very important to think, what if it were me? Yes, my moral, sorry for the background noise. I can't help. These are small pups barking. So sorry. So what if it were me? But my moral principles will be different from yours. Some people want intervention. That is fine. So I had a discussion, a day back among a doctor's group, telling about pre-operative pain. So the surgeon is telling that I don't want to control pre-operative pain, because if it is an appendicitis pain, I will be unable to understand the McBurney's tenderness. So I don't want to give analgesics. So I asked him, what if it were your son? Would you want the son to be in pain so that the surgeon will get a McBurney's tenderness? No. It is different then. The answer changed suddenly. So what if it were me is something which we can always think of. But you don't need to act accordingly. You can ask the patient, what does the patient wants? I'll just quickly share, sorry, one more presentation. I won't take a long time. So this is one thing that, are you afraid to think of your own deaths? How many? Yes, no, not sure. Anyone? Yes. Yes, Jamila, you are not afraid to think of your death. Yeah, depending on the situation. So I don't know the answer. Many people are afraid. Many people are not afraid. Some people are not sure. But very commonly, when you ask people who are afraid of death, it is usually the dying process. In our setting, when someone says me, I'm afraid to die, doctor. What is it that you are afraid of? It is usually, am I going to die in pain? Is it going to be painful? Am I going to have shortness of breaths? So it is a journey that makes people really scared of death. It is not the deaths per se, because we don't know how it feels, right? No one knows until you die. We don't know how it is going to happen. You're just out of the world. That's it. We don't know where our soul is going, the body is going, the energy is going. We don't have any clue. People are afraid of the dying process. Few hours or days. How am I going to die? Am I going to be bedridden for years? Who's going to take care of me? What about my bowel? What about my bladder? So these are or pain. So the process is very scary for many people, but not the dying per se. So this is an article written by a lady, a journalist. So her father died, and you can read, my 84-year-old father, my best friend, was going through a terrible illness. Intrusive medical procedure against his own wish. All skin and bones, he looked defenseless and at the mercy of doctors, his arms tied up, vulnerable and agonized. This is the memory that we are giving people many a times. And this will be the last memory of her father for her, right? This is something that they are going to remember. So those who have had kids in their life, who are mothers or fathers, we know that the moment you saw your kid, right? It's very, very clear in your head, right? The first sight is very, very clear. Same way, the way the person dies, we just don't forget. No one can forget it. So it's very important to give that dignified death. We don't want anyone to write like this for us, right? We don't want your father to see defenseless, skin and bones, and tied up. None of us want to see that. Sorry. The picture looks some problem. You can think about it. You don't need to tell me. But what is a better way to die? What is a better way that we can give our patients to die? So I have seen my aunt dying in the second picture. None of us could say goodbye. I haven't seen her for months because she was in ICU. None of us, her daughter was pregnant after 15 years of infertility treatment. She couldn't say goodbye. So she died in a ventilator. But some people want that. I don't want to see anyone. Just put me in the ICU. Just take care of me. I don't want to know anything about it. There are people who opt for that. That's fine. That's their wish. Absolutely fine. But what is a better way to live? But better way to go? Better way to say goodbye to your family? That is something that we need to think about. Again, autonomy, beneficence, non-maleficence, and justice. I'm making it again and again at a point so that it just goes in there. What is the primary objective when I'm caring for dying person? My objective is to mitigate suffering, to reduce the suffering. I am not going to prolong the death. I am not going to hasten the death. I'll try to correct the correctable, relieve often, but I am promising the patient and the family that I'll always give you comfort. Even if you are dying, not dying, there exists no exception to this rule. You have the primary objective of any treatment that I give should be to reduce the suffering, not to improve my saturation values, not to improve the ABGs, not to improve the electrolytes. My objective is to make the patient as comfortable as possible. It's not just physically, but as well as emotionally. So we'll start with the autonomy, whether they want to know, whether they know the prognosis. It is not when the patient starts gasping that you're going to talk about it. It is the moment they come across with the life-threatening or prolonging or progressive illness, we have to talk about the diagnosis. Do you want to know? Do you want to know the prognosis? What is the place of care? You want to be cared in a hospital or in a home? What are the interventions that you don't want or you want? And take into consideration his or her wishes. What all things he wants, who all wants to be there. So we have so many patients telling wishes like, I have quarreled with my brother. I have not talked to him for 10 years because we fought 10 years back on a property. I just want to say him sorry. It's all about forgiveness. Forgive, taking forgiveness. They may want to, so he wanted to see his brother. So brother did not come. His wife called, okay, your brother wants to see. He told, no, I'm not coming. But then we called and we talked. This is the situation that he is in. He's not going to live longer. He's in an approaching death. Why don't you just come and forgive him for what happened in the past? So that is very important. So this is a formal financial advisor written about his own personal experience. Even on the day of passing, a specialist recommended a liver function test. And the person asked, is it going to help my father to come out of the coma? No. Then why the liver function test? You might have seen this in routine hospital setting. In the moment, I mean, even if the patient is dying in an ICU or anywhere, lot of investigations being done. Every parameters will go down when someone dies naturally. Your, as I said, your electrolytes, your SATs, everything will go down. You can't die in 100% oxygen SAT. You can't die. Everything is absolutely normal unless you are hit by a bus or something where you will be 100% oxygen saturation will be there. Hit by the bus, die. Otherwise, you have all the parameters will go down. You will have infections. And then what he told, female and male nurses hurried upon, pushing and showing the inert body, robbing any peace, contemplation or prayer. Where was palliative care? We focus more on the BP, or whether the BP is okay, saturation is okay. Should we put in that line, this line? We forget about the patient. We forget about everything. We focus on interventions. So first thing, can any of the following can be stopped? Any medications, can we stop it? The patient is still taking diabetes medicines. For what? Statins to reduce the cholesterol. For what? Person is dying. Should we reduce the number of blood checks? Can we switch to subcutaneous or rectal? Can we just stop checking the BP as nurses? Instead of taking BP, go there, sit with the patient, hold his hands and take care of him. Check the skin, check the hands, whether it is cold, whether he needs a blanket, right? We can use that time, the precious time, by not checking the BP, but giving a position change, a skin care. Assume that the patient can understand. There are a lot of studies telling that the last sensation lost is hearing. Till they die, they can listen. So it's very important to talk. Even if the patient is dying, as nurses, when you go near the patient, ask permission. Can I change your position? Or, uncle, I'm going to change your position. I'm going to check your BP. I'm going to touch you. My hands might be cold. I'm going to examine your chest. He can hear, he or she can hear. So tell, communicate. Does the family understand the situation? Are there any children, small children who wants to visit their parents? Are all the religious rites facilitated? Do they want a candle or a lamp? Do they want a prayer? Do they want a pastor to come in? Anything. Have we done everything? Tell the family to be with the patient, to be with them, chant or pray or just talk. Play music. That's fine. Just hold the hands and sit there. And we need to check whether the family is coping it really well. How are they coping it? Sorry. We have gone through it. Inappropriate artificial support is called futile intervention. So this is what the lady was telling. Just give your patients only realistic treatment options, only that you can do. Allow time. People need time to understand, to process. So suppose you're going for a marriage. What saree you should wear, you will take one day, right? I'll take that. Which saree to wear, which blouse, whether it is ironed or not. And here you are talking about life and death situation. They need time. They need to take decisions, they need time. And accept the decisions for partial support. Do not reinforce a sense of guilt in the family. Oh, you could have done this earlier. Oh, you could have done that from this hospital. Don't give the sense of guilt in the family. I still remember when my uncle was dying and I stopped IV fluids because he was having secretions. And a very famous doctor called, he came to visit And he called and told me that you will be cursed because you are depriving him of nutrition. How can you let a person die without giving water? His soul will curse you. His soul will not leave you. All these things, a lot of guilt in me, right? Because I took the decision not to overhydrate because the patient was already having respiratory secretions. So it is very important to not to give guilt to the family. And never ever say there is nothing more can be done. Tell them that your care is going to be continued. You are there to take care of the patient. Although you are not doing anything, you are just there. Sorry. So it is very important to reach the people where they are, not to bring the patient to ICU. Just reach the patients where they are with respect. Don't judge them. If they don't want Ryan's tube, that's fine. If they want to look good, so they don't judge them. Oh, he wants to look good, although he's dying. Never judge them. And preserve the confidentiality. If the patient might have told you something really, really confidential, understand. And restore the dignity, even if they are dying. Only when they die, we will say dead, right? Till that minute, he is alive. So I got this from many people ask me, why do you want to work in people who are dying? I told till they die, they are living. So I'm working with people who are living. I'm not working with people who are dying. Till they die, till the last minute, they are living. So we are working with people who are living, not with people who are dying. In that way, everyone is a dying patient, right? Every one of us we don't know when we are going to die. So it's about preserving the dignity, restoring the dignity till they are alive. So that's the last slide. The most fundamental principle of medicine is love. It is not about giving an intervention. That is not what they are going to remember. They are going to remember how much care you gave them, not about how much oxygen you gave them. They are going to remember you for how much dignity you were able to give the patient. So yeah, I took 5 more minutes. I can take up a few questions.
Thank you, ma'am, for the excellent presentation. Anybody have any doubts? Please ask it.
Yes, I think it is from Yemen, so I think they prefer to get a chat answer. So I'll just chat by the time others can. I was telling it's the same in India. We don't talk about death. If I talk about death in my family, my mother will say, no, 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 don't talk about death. It's inauspicious. They say, then you're going to die. Someone in the family, that will happen to you. So we don't talk about death in our family, not at all. You'll be like hit by your parents. You can't talk about death. But when you start talking about death, people really want to listen to it. People really want that information. Just try it once. It works wonderful.
Madam Antonia asked a question: how easy to do advanced care planning in India?
Yeah, Antonia, it never happens. We don't document, we don't have a system in advanced care planning. We don't have any documentation like in UK. But we, in palliative care, we make sure that we start the conversation early. We write in our case notes. It's very difficult to start the conversation because many of them don't know about their cancer. So you have to start from there, that you have cancer, then the cancer is progressive, then you are dying. Now, what would you like to have? So it starts from talking about the diagnosis, then the prognosis, then the progression, and then death and the preferences. So it's very, very difficult. It very rarely happens, but in palliative care, we tend to start the conversation the moment it is like stage 4, multiple bone metastasis, or any advanced cancer. Then you have to start really early. Otherwise, it's very, very difficult. First, you have to deal with the relatives in India, not just one relative. You have to deal with the whole neighbors. You have to convince everyone. You have to convince the treating physician. The treating physician will say, you are losing not giving the hope. You're breaking the hope of my patient. So you have to deal with everyone. But once you take that effort, it's very, very easy when the patient is actually dying, because now everyone is on the same page. So the patient will get a peaceful death. It takes a lot of effort from our team, multiple team members involved. Not all the time we get, because when we get late referrals, we don't get the time. The patient will be gasping. You can't have all these conversations. But whenever we get referrals on time, we start talking. And we keep writing in our notes. There is no formal documentation, but I'll write, I had a conversation with the son regarding the progression. I had a conversation with the patient, what he wants when he becomes breathless. He said he is okay to be sedated. He wants to be at home. So all these things I write down so that it's easier. But it is like very difficult and not something which happens on a daily basis. But we need to talk about it. Once we start doing it and talk about it, more and more awareness will come. It's changing for sure over last few years.
Ma'am, can we move on to the case presentation?
Yes,
No
yes,
more
sure,
questions.
sure.
So Mr. Manover will be presenting a patient story today. Senior, are you there?
Hello.
Yes. Manover, so you.
Good evening. Hello.
Yes, yes, we can hear you.
Yes, ma'am. Good evening, ma'am. My name is Manogar. I am working in Atulya Hostel Living as a clinical in charge. Next, ma'am. 74 years female case. Diagnosis left MC infarct and right hemiplegia. Old known case of right MC infarct, acute kidney injury resolved post tracheostomy status. Tracheostomy done on 24/8/2021. Atrial fibrillation, MD valvular, and hypertension. Presenting complaints, clients had complaints of excessive secretion and weight loss, spasticity of muscles for all 4 limbs, not responding for commands, general weakness and teeth bite due to pain. History of illness, client is known case of ischemic stroke on left and right MC infarct. No history of allergy to any drugs or foods. She had history of post-tracheostomy status. OBG gynecology history, post-menopause status. Date of diagnosis 21/6/2021. Surgical history, bilateral cataract surgery 20 years ago. Tracheostomy on 24/8/2021. Actually, this case, known case of hypertension on medicine for last 1 year only. On 19/6/2021, complaints of sudden onset of weakness. Sorry. Weakness of the left upper and lower limb. In hospital, diagnosed ischemic stroke, right MC infarct. Treated anticoagulants and antiplatelets, PPI and laxatives, and discharged. After discharging from hospital, we are received for rehabilitation. daily monitored vitals and done for physiotherapy. On 16/8/2021, suddenly complaints of right side, upper and lower limb weakness, epilepsy shifted to hospital for further management. Again, we received a client in our facility 29/2021 under skilled nurse category for tracheostomy and activity of daily living care. No history of asthma or any COPD. Examination on examination, physical and general examination, blood pressure 130/80 mm of Hg, regularly monitored, pulse 92 beats per minute, temperature 98.1 degree Fahrenheit, and respiration 21 breaths per minute, saturation 97%, fasting blood sugar 123. Vitals are normally maintained. On examination, not responding for comments, but afebrile. Skin was dry, hydration was good. RT2 feeding going on. Cardiovascular system auscultation S1 and S2 heard. Respiratory system non-vesicular breath, normal vesicular breath sound present. Abdomen soft bowel sound heard. Central nervous system left hemiplegia and right hemiplegia. Limbs spasticity of muscles and present for all four limbs and mild bilateral pedal edema present. Genitourinary, no abnormalities. Treatment and significant investigation. Client is known case of sudden onset of weakness of left upper limb and lower limb. In hospital, diagnosed ischemic stroke. Right MCA infect. Treated anticoagulant, antiplatelets, PPA, and laxatives. Discharge. After discharging from hospital, we are received for rehabilitation. Same story only. HP 10.9 GM by DL and platelet 3.2 lakhs per CUMM, RBC 3.63 millions, blood urea 31.3 milligram and creatinine 0.9, SGOT 39.1 and SGPT 16.7, total bilirubin 0.7 and serum potassium 3.2, serum sodium 134, COVID RT-PCR negative. Medication, Eliquis 2.5 mg for prevent blood clots anticoagulant, Ecosprin 75 mg for prevent heart attack, Tonac 20 mg for cholesterol, Stocit 500 mg treatment for stroke, Levifil 500 mg prevents seizure, Mlico for multivitamin, Pentacid for prevent gastric problems, Leofen 10 mg used to relieve rigidity, syrup Justifer XT treatment for anemia, syrup KCl to maintain potassium level in blood, nutrients powder through RT feeds, maintain 2000 to 2500 kilocalorie per day, Neb Budecort and Neb Livolin for reduce secretion and bronchodilators. Psychological aspects need counseling, health education about disease condition for family members. Client lost their self-confidence due to disease condition. Rehabilitation team trying to reduce muscle rigidity. Nursing team focused to prevent bed sore and prevent infection. We are trying to reverse trachea as well as digestive. Main concern, tracheostomy care to prevent bed sore, to prevent infection, to reduce secretion, anemia, physiotherapy, psychosocial stressor. Summary, this case, frequent question changing and suctioning, daily monitoring for intake output charting, continuous vital monitoring to use advanced dosage device, daily pain and consciousness checklist, GCS or monitoring, daily checklist, basic care, aspiration, airway management, personal hygiene and monitoring tools, etc. Daily tracheostomy dressing and HMC filter checklist, weekly discussion with medical team and primary treating team, weekly monitoring our blood glucose level with monthly cross-checking blood counts, physiotherapy for 2 sessions per day, client clinically improved. Discussion points, financial support, need to discuss about tracheostomy reversing, peg feeding, and to improve quality of life. Thank you.
Thank you, Managar, for the presentation. Anybody need any more clarification regarding this patient study? Please ask them. So otherwise, we can move on to the discussion points. I hope nobody's need any clarification regarding this patient story. The presentation is clear. So we can discuss patient. This patient need a, uh, I think, what about the general condition of the patient right now? Manohar?
Right now, patient conscious but not responding comments, ma'am. We use splint for reduce muscle spasticity.
What for?
Splint.
Splints.
Yes, ma'am.
Okay. Okay.
Otherwise, no improvement, ma'am.
Anybody want to comment? Anything?
Last review, doctor told to reverse RT tube, Riles tube, and to insert peg feeding.
Okay.
Because of
So what do you think? Others comment. If you the doctors prescribe, the doctor is willing to put peg feeding, right?
yes, ma'am.
Okay. So so this is our last session. What do you think, nurses? Please comment. Any answers? Anybody?
I did not hear the question clearly. Please repeat the question.
Yeah. From this patient is on semi-conscious stage, but the doctor wants to put a peg feeding. So how will you respond? See, if your doctor suggests peg feeding for a semi-conscious patient, what is your idea? So Kalaivani said to improve the nutritional status, hence the patient is conscious and not obeying comments to prevent aspiration as well they might be put peg feed. Others? Any other answers? Madam, you want to suggest anything?
Yeah, so I would start with the slide where it is mentioned clinically improved. So again, what do you mean by clinically improved? For me, this patient is still bedridden, not obeying commands, not responding. For me, he's still the same. So I really sometimes don't understand what doctors mean by clinical improvement. So there was one old lady. They didn't have children. Her husband was going through the same situation, multiple system disorders, and they sold their land, only land, the piece of land they had in a big private hospital, and then they ran out of money. So then they came to us with multiple bed sores and lot of issues. And then she used exactly the same word. She was working as a nursing assistant in her past, so she understands the medical terms. So she told me all the doctors will come for the rounds, and when I ask them how is my husband, they say he's clinically improving. I could not see any improvement. He's deteriorating. I could understand he was deteriorating. He was smelling bad. He started having bed sores. He was having, because she worked in the hospital for many years. She understood what's happening. She told he started having contractures. He was not even properly using his arms or legs. He stopped taking feeds. Then they put in a rice tube, but they kept telling me he's improving. We think he's good, he's improving really well. So she asked me, I did not understand what you mean by improvement. For me, my husband was deteriorating. So they do blood checks every day, and then they felt the patient has improved. So I told, I think sometime back also, what do you mean by the clinical improvement? That's very, very important question that we need to ask ourselves. What are we improving? Are we improving the blood results on a paper, or are we improving the patient's condition or comfort? So that is one thing that we need to remember. So Antonia has asked about the correction. So I'm coming to that, connecting that to this. Correcting the blood, HB. We always give transfusions. There are some illness like where you have to give transfusions, right? Like if the patient is having some blood disorder which needs constant transfusions, then yes. Suppose this particular patient has something dropping below 6, HB below 6, and multiple transfusions. And I would ask whether the patient is dyspneic and fatigued because of low HB. If the patient is telling, I'm so fatigued, I'm so breathless because of this, and then we look for correcting the correctable. When we see that, okay, this is because the HB is too low, that is why the patient is dyspneic and fatigued, then I might go for transfusion if it is giving a subjective improvement for the patient. And sometimes the patient say, okay, I feel good after the transfusion. I feel less breathless. I feel less tired. Okay, you've done something which is good for the patient. I'm not going to look at whether HB has improved how many points. I'll just ask the patient, are you feeling okay? Are you feeling good? If you're feeling good, then you can think about transfusion next time when you become so tired. But not for improving my HB values. So Manohar is telling that this patient's not having any bed sore or infection. So peg feeding cannot prevent aspirations. You have your saliva in your mouth. So you will have micro aspirations even when you have a rice tube. And look at the list of medications that the patient is on. Who can afford this kind of medications? I cannot afford to buy these many medications, right? So many medications. So that is one thing that I will ask the treating doctor. I won't take a decision because this patient has a lot of comorbidities, right? Lot of issues, a lot of multi-system issues. So I will not take a decision. I am not an expert. I will ask the primary treating doctor, can we sit and have a meeting? This patient is progressing. He has multiple systems involved. He has problems in swallowing. He's not responding to comments. How should we proceed? Is there any medication that you think is not beneficial at this stage? Just ask the question. Many a times they will say, I think maybe we can stop the multivitamin. Why are we giving multivitamin? So these are the things that we need to sit. We cannot take a decision on our own, right? We can't just cut off all the medications and tell, no, I'm going to take care of you. I won't do that. I will ask the primary treatment, write a letter, call or ask, can we do something? It's too much of medication and I think patient is actually progressing. And syrup Gesti for XT for anemia. It will take months to improve the HB levels with syrup and the tablets. Is the patient going to live for that long? So these are the things that we need to ask because when you go with the relatives, the doctor tend to write repeat all medications for 1 more month. That's it. So we have to tell, I think the patient is pretty bad, bedridden, not responding, not taking orally. So should we reduce some of this medication? First step. Then I'll sit and talk with the family members. What is the goal for you? What is it that you want to see? If they say no matter what, we want to feed him. Then I'll ask why. What are you going to achieve out of this feeding? Oh, we have to keep him alive. We can't keep him hungry. So then we can explain how patients don't feel hunger when they have these kind of illnesses. They are not actively doing anything, not even moving. And Manogar, thank you. It's a good thing that they don't have infection or bed sore. That's very important, actually. That's a good thing, and that has to be maintained. If this patient is in your setting, you have to maintain that good skin condition or infection status till the patient dies. That's the best thing that you can give. Preventing infection, preventing bed sore, reducing the secretion. So one thing that helps in reducing secretion is glycopyrrolate. It is an anticholinergic drug usually used by the anesthetist as a pre-medication to dry up all the secretions when they intubate. So injection, glycopyrrolate is one thing that you can use. You don't need to give it as injection. You can either give it subcutaneous. Sister Shiba, are you able to type so that you can just type the dosage, or I'll type. So you can either use injection, or the same injection can be given sublingually. 2 mg. So you can give that's 200 microgram. You can break the ampule and give it under the tongue in a home setting, or you can give subcutaneously. It will reduce the secretion. But before giving glycopyrrolate, I'll make sure that the positioning is correct. The patient is not lying down on supine position and that cannot happen. And what is that noise called? Has someone heard such noise when someone dying? There's a typical noise that patient makes when they die. Death rattle. Very correct. Very correct. Very, very common. Any patient who goes through end of life, they'll make this gurgling noise because of the pooling of secretions on the back of the throat. The patient is unable to swallow, unable to spit it out. So there will be pooling of secretion in the back end of the throat, which you cannot suction because it's much lower than that. There are a lot of secretions in the trachea. So how much you can put in your suction tube? Only till throat, right? You are not suctioning into the trachea. So suctioning may not work there. That's, I think, one thing that I missed during the presentation. That death rattle. How to manage the death rattle. That sound is very, very common. Explain the patient's family that it is not infection. It is not that patient is struggling for breath. It is the pooling of secretions in the back of the throat. Positioning is very, very important there. Not suctioning. When you poke with the suction tube, you're poking in the throat. That itself causes more and more secretion. So it's very important not to put the suctioning tube when someone has death rattle. And give, if it is too much, even after positioning, the patient is making a lot of noise, you can give injection glycopyrrolate either sublingually, or you can give it as injection. So these are the issues that we need to understand and explain the family. So here in this patient, the patient is lying down. He's not imminently dying. He's not actively dying, but he is progressing. This is the good time to have a conversation with the family. This is the situation. Just start talking about end of life care right now, so that you will understand what the patient's family wants. Later on, when he has another attack of infection or respiratory distress, they'll ask you, can we keep him comfortable? So it is a right point to start the conversations about end of life care for this patient. I'm not answering any of the question Manogar asked. That is for you to think how to improve quality of life. This is the point. Start having the conversation with the family so that we can improve the quality of life. Now they all understand that condition is progressive. It can progress. Now he is not actively dying, but he can go there. If he goes there, what do they want? Do they want to take him again to an intensive care? He's already intubated. What is next? So all these questions have to be asked and planned and documented at this point of time. That is what you are supposed to do if this is your patient. I'm not bothered about the financial support or the peg feeding or anything else. I want to have the conversation to start right now. That is the treatment that I'm recommending for this patient. Document it, have the conversation with the primary treating physician, cut down whatever unnecessary medications they want, and plan and ask what do they want in future if something happens. I'm stopping there. Yes, Ali, reducing the secretion needs chest physio. Chest physio is something that we can teach the caregiver. Positioning and patting on the chest, tell them how to do the tapping. That's very, very important.
Thank you, ma'am. Also, if you respect the patient that peg feeding, if you go on peg feeding, the patient has to undergo a surgical procedure. So this patient is not able to talk, only respond. So we are the persons to advocate for that patient. Okay. If the family members suggest these things, you have to talk to the patient family. So we need to understand that the food is a symbol of love. And as ma'am said, we have to conduct a family meeting and respect. So we have to elicit their concerns, and always we have to respect their concerns. Okay. So then you can tell. So after that, if they share all those points, then after that we can tell them that. So what are the benefits and what are the risks? If you suggest, if you give these options to that loved ones, so what are the risks and what are the benefits will be get? So then they will decide. So always you have to give a proper education to the family members, and give a psychological support and reassurance. Proper reassurance is needed. So here always we have to think about, so their loved ones going to lose their family, they are going to die. So they are they are going to lose their loved ones. So they it's very difficult to cope their situation, that patient family also. So always we have to think from the patient side and from the family side also. Okay, here if you give more fluids to that patient, so there is a chance of more fluids and more that nausea, vomiting, and secretions and all. So that will be distressing to the patients in end of life. So always you have to think like that. So, I think anybody, any more questions? Okay, thank you. So as we discussed earlier, this is our last session. So you can give your feedback, and if you need, if you give any suggestion, so we need a suggestion. So we need to improve our course. So if you have any suggestions, please tell.
Sister Shiva, shall I leave? I have another session at 5.
Yes, ma'am.
Thank you
can
so
go.
much, everyone.
Thank you, ma'am, for
Thank
the
you so
excellent session. Thank you. Your feedback is very valuable for us. We need to improve the course structure and all. So if you have any suggestions, please